Let's get things started. So I've got a wonderful lineup for today. I'm so excited to go over the FDA expert panel on hormones. But as we just get ready to begin, let us start with just kind of centering ourselves a little bit. So we're going to go into our four-part kind of breath. Slow down, breathe, appreciate, and smile. So let's begin. All right. So today we're just going to slow down. We're going to get comfy in our chairs, in our seat, wherever we are right now. And as we sink into our chair, let's just take a few simple deep breaths. And today we'll go in through the nose, and then we'll go very slowly out through the mouth with a gentle sigh. So it's in through the nose, and then fully exhaling, getting that last drop of breath out through your belly. And a breath in again through the nose. And just one more breath. Just feeling the tension drain away from your body, allowing your body just to come to a place of quietness, of calmness, of stillness. And now we'll bring in a thought of appreciation. We know one of the best ways to make our body to feel good is when we show appreciation and gratitude. So begin to bring something to mind today that you appreciate. A person, a thing, an event, whether it was today, the weekend, or last week. Bring that into mind. And as you bring it into mind, sometimes it helps when you put a hand on your heart. Because that thing that you appreciate usually makes your heart swell with joy. It can make your heart swell with happiness. And it's these emotions that are going to shift our physiology. These emotions help us to feel good. These emotions bring just a little bit more joy into our day. And as you think of that thing that you appreciate, let that smile just come naturally. Thank you. And as you're ready, I'll just get you to open your eyes back into your space and ready to learn today. Thank you, everybody. So we'll begin to get started. And so as we begin, welcome everyone to another week of the Inner Circle. So today I'm excited to do a review of the FDA panel on menopause. This was an expert committee that met just on July the 7th, just a few weeks ago. So I'm going to get into some of the slides and leave it open to some questions that you may have as well. So let me begin to share my screens with you. So here we go. You know, here in the Inner Circle, I try to bring you the latest of what's happening to really expand your wisdom as to what's going on with you and your body, and to give you new insights into health and longevity. So what was this expert panel? So basically, the idea came about that it was called by the new FDA commissioner, Dr. McCary, to speak on the FDA stance on menopause, but in particular, the black box warning that was placed on vaginal estrogen. So in this panel, what they did is they called some of the leading experts in America together to start to discuss why this black box warning should be removed, but it also highlighted a few other great aspects in women's care. So some of the key takeaways, and then we'll get into the slides. But basically what they discussed was, so why did estrogen get a bad name in the first place? So in 2002, so this was 2 years after I graduated from family practice, a study was released which said that it highlighted some risk associated with hormonal replacement therapy. But what do we know now in 2025, looking back on this study? that the results of the trial were overrepresented because it was basically for women that were age 60 and beyond. Because what the study was looking at was the safety of hormones after 60. And so a lot of things were highlighted, but I'll discuss some of the things that were released that we know now from this study about the benefits of hormone therapy. So what was the panel? The overview that the critics say the warning has deterred safe, low-risk therapies. So basically, you'll hear some of the panel experts speak, and I'm going to post just one of them, the video. But basically, because these warnings are listed, there's a lot of women that are losing out on the benefit of hormonal replacement because they're worried about the black box warning. So maybe they're worried or their clinicians are worried. And this is why a lot of GPs have steered away from hormones, because they still think it's unsafe because the message hasn't been translated to the safety. And a lot of it is because this warning still comes on the labels. But the panel urged revision or removal, especially for low dose vaginal estrogen. Okay, this is the number one. And we know now low dose vaginal estrogen is being used even on women that have had breast cancer. So some of the highlights that were discussed, that low dose vaginal estrogen is very minimally absorbed and that it treats genitourinary syndrome of menopause. So I'll highlight the doctor that spoke about that. So really vaginal estrogen, it's one of those products that I think a lot of us in the hormone space would almost agree that it could be sold over the counter, right? If we look at what's sold over the counter these days, if we look at Tylenol, well, over 4 grams of Tylenol a day is actually very dangerous and it can cause liver diseases. And that doesn't take very much Tylenol to put you overboard. But low dose vaginal estrogen, when used, it helps so many women. We'll discuss some of the symptoms, but we really feel that at least the black box warning should be taken off. That systemic pills and patches carry different risk profiles. So this was highlighted by the speakers as well, so that we can't label everything with the same warnings. And experts strongly advised the contrast between a vaginal hormone that is taken versus something that's taken even orally or something that's taken in a higher dose that's absorbed through the skin and not through the vagina. The other thing that was talked about was this whole discussion of the evidence of the timing hypothesis. And it's clearly stated, so HRT initiated within 10 years or before the age of 60 reduces mortality, that's death, okay, coronary heart disease, that's heart attacks, and dementia risk. So this was discussed by the panel. So I'm going to get in a little bit into some of the speakers, but I presented this to you because the whole review is over 2 hours. It still is fascinating if you want to really go and deep dive. I didn't list all of the speakers here today, but I did list some of the key highlights and from some people that you may have heard about before, because some of them are very visible on social media. Okay. So the first person came up that I want to discuss is Dr. Rachel Rubin. So Rachel is one of my teachers. She is a urologist based in Washington. She's a urologist. She's a bladder and kidney specialist. So you might think, why is she such an advocate for women's health? And she's very passionate about sharing her story, because she sees the number of women that suffer from recurrent bladder infections, but she also sees the risk associated for women that get admitted to the hospital on an annual basis for systemic, like sepsis from bladder infections. And when she's done plenty of research, and she talks about this openly on her YouTube channel, her Facebook page, and on her Instagram, but she speaks about the savings that we could have if every woman were simply given vaginal estrogen to use. So just some of the takeaways from Dr. Rubin's talk, okay? So she spoke a little bit about how mortality from UTIs is increasing. So basically women are dying from bladder infections. So some of you might think, well, it's not such a big deal. You just take antibiotics and you get rid of it. But some of you might have had a kidney infection. So that's when the infection goes from the bladder up into the kidneys. You get fever, you get vomiting, you get back pain. And think of this in a 60-plus-year-old female. This can lead to widespread infection in the bloodstream. So for those of us in medicine, we're taught that when an elderly person comes in, if they have a fever with no cough, that we have to look at a urinary tract infection as their number one source of infection. And a lot of times this can be reversed through vaginal estrogen. So local vaginal hormone therapy significantly reduces UTIs. It is safe for everyone and does not increase the risk of breast cancer, endometrial cancer, stroke, heart attack, blood clots, or dementia. Vaginal estrogen is completely safe. The black box label, it deters clinicians and patients. So doctors don't want to prescribe and patients are scared. And she actually estimated the savings in Medicare in the US between $6 to $22 billion a year for a simple cream that can run, $20, $30, not expensive at all. So she went on to discuss the symptoms of genitourinary syndrome of menopause. So GSM is the term that we talk about. So in menopause, you go through many symptoms, right? So the hot flashes and the sweats, we call that vasomotor symptoms. But any of these we call GSM. So this can be recurrent bladder infections. And the thing to remember, so yes, this can be women anytime from their 40s, but as well, women that are in their earlier ages, especially if they're on the birth control pill, they can still have an issue because when you're on a birth control pill, you're actually given synthetic estrogen and synthetic progesterone, and you shut down ovulation. So when you shut down ovulation, you shut down your actual natural estrogen, estradiol, and progesterone from being released. So women post-pregnancy, women that are on the birth control pill, they can still use vaginal estrogen if they're getting recurrent bladder infections. So really important to know. Also, urinary incontinence, because we know that some of the pain, some of the issues with urinary incontinence comes from the estrogen receptors that are around the opening of the urethra. Because when you think about it, where you pee and where your vagina, they're very close together, but we have estrogen receptors in that zone. So pain with urination. So women that have conditions like interstitial cystitis, one of the things that I think about, do they need vaginal estrogen? Of course, vaginal dryness, itching or burning, decreased lubrication, pain with sex, those are definite reasons for vaginal estrogen, but also diminished orgasm or arousal. We want to think about estrogen within that area because the clitoris, which is very much responsible for assisting with orgasm, it also has receptors for estrogen, okay? So new guidelines were brought about this year from the three different societies, the American Urology Association, the Society for Urologic Foundation, and the American Urogyne, I think, guidelines. So all of these groups had more discussion to say about the GSM. So Dr. Rachel Rubin was on this committee that brought about the new guidelines. And so she brought this to the committee to discuss about it. She did speak a little bit about the FDA approved treatments for genitourinary syndrome of menopause. So the vaginal creams, vaginal inserts, and vaginal rings. So in Canada, we still don't have access to a vaginal estradiol cream. Okay, so many of you are probably taking Vagifem. So Vagifem is a little tiny pill insert, which is vaginal estradiol 10 micrograms. The other vaginal estrogen that we have is Premarin, but Premarin is conjugated estrogen. It's not the same as body identical estradiol. Okay, so why don't we have vaginal estradiol in Canada? That would be a question. Okay, because Vagifem is a little bit more expensive because it's on a little tiny insert that has to be used. There are actual vaginal rings that can be used as well. I find most patients don't use them. But when we start to think of the elderly or people that might be in nursing homes, this is where the vaginal rings can come in, because they only need to be inserted every 3 months, and they give a very low dose of vaginal estrogen. So this was her overview of the genitourinary syndrome of menopause. So then I want to move on to Dr. Pinkerton and Dr. Mansoon. So Dr. Pinkerton is here, and she was speaking for Dr. Mansoon. So both of these women, as you can see, they are a little bit elderly. They were there in 2002. You know, Dr. Rubin was just finishing up her training, but they were there, and they really saw what changed in the field of women's health when this message came out that the WHI said we have to get all of the women off of these hormones. So this is a slide that Dr. Pinkerton put up. Actually, she was speaking on behalf of Dr. Manson, and this was from 2013. So this is the benefits and risk of hormonal therapy in women in the WHI trials. Okay, I'm going to show you this video because I really want you to hear what she had to say. But even before she gets into it, what you're going to see here in the slide. So this is the risk and the benefits. So on the top, they're looking at, this is what was used in the trial was Premarin and Provera, okay? Because that's what was used at that time. We didn't really have Prometrium or this micronized progesterone, which most of you are on right now. And also we were using this conjugated estrogen, which was the horse-based estrogen. We weren't using estradiol, which is body identical. But even with this data, you can see the safety of what was used. So this was estrogen, and so it was Premarin and Provera together. You can see the risk, and then you can see the benefits. And then this was the risk of estrogen alone. And then at the bottom, this part of the slide was a little bit harder to see, but it was the ages. And what basically was shown is that at an older age, when they did the studies in 2002, there's greater risk of heart disease when you get beyond 60 and into 70. Now, this was using Premarin and Provera, right? But if we look at the younger ages, 50 to 59, we know that you actually have less risk of heart disease, less risk of breast cancer, yet less risk of osteoporosis. So let's listen here to Dr. Pinkerton discussing this. So let me open this up here for you. We'll just hear a few minutes because I thought this is the one that, you know, so many of you would have some questions about. And I think it's worthwhile just having a listen. Just a few minutes here.
Excellent. Thank you so much. Our next presenter is Dr. Joanne Pinkerton, also presenting for Dr. Joanne Manson.
So I'm going to start by being the voice of Dr. Manson.
Actually, let me just stop.
Who wanted to be here. She is at the Endocrine Society.
I'm just going to put the sound up here a little bit. Let me just reshare again with all you guys. Share sound so that we can hear the video really clearly.
Excellent. Thank you so much. Our next presenter is Dr. Joanne Pinkerton, also presenting for Dr. Joanne Manson.
So I'm going to start by being the voice of Dr. Manson, who wanted to be here. She is at the Endocrine Society out in San Francisco, but she really wanted to present her data to show how to combat this misinformation. Because just like Barbara, when the WHI came out in 2002, the phones rang off the hook. I had an open session. 600 women showed up, just frightened to death that they had taken something that was going to kill them or give them dementia. And so they suffered, and 25% went back on. But this data that I'm going to show you is come from two parts. Wait, somehow okay. I'm going to talk about primarily in the WHI trials that were starting on average age women of 63, but she divided it out, and you can't see this, but she wanted this data presented. At the very bottom of the slide, there are 3 columns. The first one is age 50 to 59. The second one is 60 to 69. And the third is 70 to 79. The estrogen is in blue, placebo is in orange. And if you look on the left, at that slide, you see very few absolute events. You do see benefits in terms of fewer breast cancers and less mortality, but very few events in that group. If you jump all the way over to the right-hand group, that is the women starting at age 70 to 79 when they might already have cardiovascular events or heart events. And what you see is an increase in heart events and in stroke and in total mortality. So that differentiation started to happen, but it didn't happen until 2013. And then in 2017, based on this next data that I'm going to show, we rewrote the NAMS position statement. And with that, we said, let's look at just those women that we want to start hormones on, the women under age 60 within 10 years of menopause. So the top of the slide is the conjugated equine estrogen and the synthetic medroxyprogesterone acetone trial. And the second table is the conjugated estrogen alone trial. And what you see when you have conjugated estrogen and you add progestin, the risks are in purple, and you can see them at the top, and you're going to see an increase in heart events, stroke, and blood clots, but very small numbers in this group. And then the benefits in terms of breast cancer and the all fractures, all cancers, and all-cause mortality and diabetes. Those things went down, they didn't go up. When you look at the CEE trial, you're going to actually see more dramatic benefits because estrogen alone has a very different effect than when you combine it with the progestin. And you'll see that the heart events they went down instead of going up. We saw a slight increase in blood clots because it's an oral product. We saw, again, a decrease in, a true decrease in breast cancer, fewer cases, decrease in fractures, decrease in all-cause mortality, and a decrease in diabetes. So I really want you to focus on that data because what we're telling you is that if women are between 50 and 59, the outcomes are more favorable in that young age group and also more favorable for estrogen alone than the synthetic progestin. They only looked at one formulation. You've heard transdermal is different. You've heard progesterone is different from the synthetic progestin, but that's not what was tested in this trial. And everything and every warning that is on systemic estrogen is based on this trial and the data across the board, not the data that ought to be being put out, which is the data from 50 to 59. And E alone is significantly better for younger women in terms of heart attacks, all-cause mortality, and the global index than women who are 70. And over the long term, which I'm not presenting that data, but what they found was that estrogen alone led to a reduction in breast cancer incidence and a reduction in breast cancer mortality. Estrogen and progestin did not show an increase in breast cancer mortality, although a slight increase in breast cancer risk. And what we know from the French E3N study is that there's less risk when you add progesterone than the synthetic progestins. So, Dr. Manson, thank you very much for your data and all the work that you've done. And then I'm going to switch over and become myself. So now I'm Dr. Pinkerton, and I was the past president of NAMS and executive emeritus director, and here to talk about this. And what I want you to think about is my patient Joyce. So she's had genitourinary syndrome of menopause. I'm going to call it GSM, and I've tried to help her. She stopped having sex because it was so painful. This year she comes in, she's having recurrent urinary tract infections. She's had 3 in the past year. One of them made her really, really sick. She almost was septic. And so I convince her. I do a vaginal pH. I show her that she's got a pH of 7. I talk about all the changes. She says, I'm going to do it. I'm going to do it this time, Dr. Pinkerton. She goes home. She pulls out the tube of estrogen, and it says, warning, endometrial cancer, cardiovascular disorders, probable dementia, and breast cancer. She looks at it. Her partner or spouse looks at it, and they throw it in the trash, because they're afraid that improving their sex lives is going to cause breast cancer, dementia, or death from heart attack or stroke. Why is sex important if it's going to kill me to be able to do it? So I want to make the point that, and I know that Heather said this, but the boxed warning is not supported by science. It harms women. It reflects an estrogen class labeling, which was extrapolated from the systemic hormone therapy trial that I just showed you, average age 63. It overstates risk. there is an absence of randomized clinical trial or consistent observational evidence linking vaginal estrogen to GSM to cancer, heart disease, dementia, blood clots, or stroke. And if you look at blood levels for systemic hormone therapy, they are dramatically higher than the levels we see with these local vaginal estrogens dosed to treat GSM. So Dr. Santon has shown that our basal estradiol levels when we're postmenopausal range from 1.5 to 12 picograms per ml, median of 4.5. When he looked at all of these low-dose therapies, the range was 4 to 14 picograms per ml. Notice that that's essentially the same. The vaginal ring goes up to 19 on day 2 and then is not detectable for the next 3 months in women. And so therefore, whether it's a vaginal tablet, an insert, the ring dosed for GSM, or the creams that are dosed low, we do not have any biological mechanism to explain how it could cause heart disease or a stroke or blood clot or dementia.
So I think this is pretty interesting. And so this part of the study reviewing the risk, the cardiovascular risk, I think is one that all of you probably have found interesting. Now, let me get back to share the rest of my slides, and then please, we'll have lots of questions at the end as well. Okay. So again, this is where all the fear came about. And now we can see the safety, but the big thing, all-cause mortality. So with hormones, there's less chance, less likelihood of death, okay? So we're moving on to Dr. Kelly Casperson. So Kelly Casperson is also a urologist. So her take was on testosterone and the benefits of testosterone therapy. So, you know, she goes on, again, she's very active on social media if you wanted to follow her. And she is quite dynamic. I do like listening to Kelly, but she talks about testosterone and how, number one, that testosterone is needed throughout the body. Both men and women need testosterone. And then when we look at the brain, we look at total testosterone and gray matter volume. So if you look at the premenopausal group and the perimenopausal group, we can actually see areas of the brain that change. It's a little bit harder to see, but you can see within the brain that there's these yellow areas, okay? We can see around perimenopause that these yellow areas are beginning to become reduced because as we're younger, we have good amounts of testosterone, and then this number starts to go down anytime after women are 30. Or again, when women are on oral contraceptives, testosterone levels often drop very low because of the impact that the synthetic birth control pill is doing to suppress testosterone in the body, okay? She also spoke about, you know, testosterone and how it impacts cerebral blood flow. So again, if you look at this, a perimenopausal or a postmenopausal group, you can see areas, especially in the hippocampus, okay? This is one of the areas. The hippocampus is the memory center of our brain. So as we go through the menopause transition and testosterone drops, then we're losing this area in the hippocampus. Why do our memories start to go? Okay. So testosterone has many more roles to play. So it is in every body, male and female, she speaks of, that it is a neurosteroid. So we often forget that hormones are steroids. I remember having a patient once and she had rheumatoid arthritis. And so she went to the specialist and she was in perimenopause, and the specialist started her on drugs, started her on prednisone for her rheumatoid arthritis, started her on methotrexate, and I had started her on progesterone for perimenopause. And then she came back later and she said she had stopped the progesterone. She didn't really see the benefit. But what it was is that she also didn't realize that progesterone is a steroid. Estradiol, testosterone, these are steroid hormones that can be very powerful, very effective on working on different aspects of our body. So again, testosterone was a steroid, neurosteroid that Dr. Casperson spoke about. She spoke about the availability of it, that, you know, if we look at men, there's 12 FDA approved products with over 6 months of safety data for men using testosterone. For women, there are 0 FDA approved products. Okay, so why is this? That in America, they have the FDA, there's a voucher program for women who are dosed testosterone to expedite them getting approval for it. And she's also working, many are working with the DEA to deregulate female dose testosterone. So think about it. So testosterone is classed as basically as a controlled substance. So when I prescribe testosterone, there's a specific way that I have to write it. And this came about because of the work of, back in the day when people were abusing, maybe there were bodybuilders at the time, but it has a different classification. So it's limiting the number of women and men that can sometimes have access, but for sure the women. So this is the same in Canada. We don't have an FDA, we don't have an approved product for women. So if I dose you with testosterone, I'm either using a male Testagel, which I typically don't use. It can be much cheaper, but it's harder to dose. Otherwise, we have to get testosterone compounded. So we have to mix it at a special pharmacy so that I can give you the 2, 3, 4, 1 milligrams, whatever is needed for you. So she went on to speak about that we need testosterone to have appropriate for women for use. So then we have male physicians were on the panel as well. And again, I put some of these guys up because I wanted you to see these are physicians that have been around for a long time. So this is Dr. Philip Serrell. He's professor at Yale School of Medicine in Obstetrics and Gynecology. So he went on to talk about the significance of estrogen and what's happening when women have been avoiding it, okay? Because for over 20 years, women got scared in 2002. So now what are we seeing? So menopause symptoms affect a woman in many ways. Her sense of self, her daily functions, her relationship with her spouse and her family. So for today, he focused on the effects of untreated symptoms in the workplace. That was one of the papers that he wrote, okay? And then he spoke about diseases with increased mortality rates are seen in young age women following surgical menopause, most of which can be reduced by estrogen replacement. Unfortunately, the great majority of women avoid estrogen therapy. I will describe a death toll due to estrogen avoidance in young age women since 2002. And then he went on to speak about how estrogen, biologically, they first found it in like octopuses, and it was quite interesting. But I want to speak to this, that estrogen for so many women for 20 years, right, has been avoided. My mom went through a very early surgical menopause at 28, and mom went on to have some issues with anxiety. She has osteoporosis now. And I really feel that she should have been offered hormonal replacement therapy. So now we're playing catch up on building up her bones. But yet at 72, she is on hormonal replacement therapy to help her. I saw a patient the other day and she was on estrogen therapy because, again, she had early surgical menopause. It had been started by her gynecologist, but it was still several years out from when she was given her estrogen therapy. But then she went to see her physician. Her blood levels were somewhat elevated. The physician stopped her estrogen therapy, and she went through quite a significant depression and anxiety over 9 months, and it was really affecting her family situation. So this is true that, the lack of estrogen can cause significant impact for women, in particular, those that are not given it for early, when they've had early menopause. So for anyone that's under the age of 40, and if you've had surgery, most likely you need to be on hormonal therapy. And for sure, those that have their ovaries out completely need to be on estrogen, progesterone, and testosterone-based therapies. So then next we had Dr. Roberta Brinton speak. So she is the director on the Center for Innovation in Brain Scientist, right? So she is a neurologist. And again, she does work for a few private companies, but she's thinking about menopause and its impact on the brain. So, and I've spoken before about Alzheimer's. We know that, Dr. Lisa Mosconi wrote the book called Menopause Brain, because we see this increased risk of Alzheimer's in women. So some of her highlights: 2 out of 3 cases of Americans that have Alzheimer's are women. Okay. The menopause transition corresponds to an initiation, a prodrome, or a preclinical time of Alzheimer's disease. You know, I have patients almost every day that say, Dr. Keenan, I think I might have Alzheimer's, or I think my memory is going. Well, guess what? Most of the time, this is just the menopause transition, but we do know that estrogen has a humongous impact to play on the brain, and that for women, we can see a much higher incidence of Alzheimer's disease. So she spoke about the preclinical stage. So we know now that Alzheimer's is not something that's diagnosed at 75. It can start up to 20 years beforehand. And then up to 10 years beforehand, we start to see things changing. So she talks about this menopause transition when women speak about brain fog. Now, brain fog can come from many reasons. For sure, the estrogen impact, but also the role of blood sugar and its impact on the brain. So we need to address that role as well, the sugar impact. But the other thing that we see is this overlap of symptoms, because we know that with menopause, as estrogen goes down, blood sugar often rises because insulin resistance develops. So if you see this slide, if we go back here, and if we look at the risk of heart disease, so we can see that there can actually be a benefit, especially if we look lower on in the study, but there's actually a lowered risk of heart disease when estrogen can be used. Okay, a lower risk, sorry, I'll go back here again. Look at the diabetes data. That's what I should be looking at. A lowered risk of diabetes this was with, again, Premarin and Provera, but with estrogen, Premarin alone. But I can tell you, I see this a lot, that we see the change both in blood cholesterol and blood sugar as women go on estrogen. But she's talking more about estrogen in the brain. So she talks about the menopausal decline in brain glucose metabolism. We can see a rise in beta amyloid and the loss of white matter. So think about it. As you go through menopause, your brain is changing, right? You're losing the folds of your brain. So this can be an estrogen-based impact. So we need to begin to think about, how do we take action? She talks about the hot flash is the release of brain heat, okay? The loss of estrogen, it impacts the mitochondria. So the mitochondria, they're inefficient heat generators. We get an elevation of this reactive oxygen species. And I've spoken about this before. So this is oxidative stress within the brain, okay? And then we can get a leak of heat and radiation. It can cause this vasodilation, which causes a release of brain heat, which can kind of stimulate the hot flashes. So this is kind of what's going on in the brain, but it is in the brain, right? So if we're having a loss of estrogen that's causing this heat, then we can also see other changes that are coming. So she speaks about menopausal hormone therapy, reduced risk of age-associated neurodegenerative diseases. So not only Alzheimer's disease, Parkinson's disease, general dementia, but also in this category, multiple sclerosis. And we need to, I see this again, that women are more prone to MS as they're starting in their 40s. They're going through a time of estrogen decrease. And also ALS, also known as Lou Gehrig's disease, we can also see this come with the change in the estrogen levels in the brain, okay? Again, there's so much I could go on, but I'll just, then she kind of gets into the kind of the specifics about the types of estrogens that are used, but this is really interesting. She speaks about menopause transition, the starvation response, metabolic and immune reprogramming of the brain. But basically what we can see that there's a lot of change in glucose metabolism. So if we look here, so one of the things that's happening, the way that the brain uses glucose changes as we get older, and that's a function of estrogen. Again, there's a lot of other impact, but estrogen is one of those key ones. And we can see here, this pink line, how the brain is using glucose and then how this becomes changed as we go through postmenopause. So highlighting the fact that basically a change in estrogen can impact your brain. Okay. And then Dr. Vonda Wright. So Dr. Vonda Wright is an orthopedic surgeon. She wrote the article on the musculoskeletal syndrome of menopause. She speaks about estrogen and its impacts on joint aches and pains. But in the panel, she was speaking about the benefit on bones. Okay. So 70% of all hip fractures are in women, 30% of death in 1 year of a hip fracture. So if you get admitted to the hospital with a hip fracture, there's a 30% chance that you will die within 1 year. Okay. 50% of those women are going to not return to their regular function. So if you're admitted at age 75 and you were in the hospital, then 30 out of 100 women will die, but 50 out of 100 women won't go back to their baseline status. Okay. 40% of all women will develop osteoporosis. That's a lot, right? 20% loss of bone marrow density happens at menopause. And then she spoke that 50%, 1 in 2, that's half of you, okay, will suffer an osteoporotic fracture. That's what we're seeing now. But by 2040, her estimates are, when they look at the surveillance, is that we're going to have even double this risk. Okay. And she goes on to describe a story of a patient and the impact that it had with a patient that had a hip fracture, both the cost of healthcare for the person, especially in America, and also the long-term impact that it had on the families. So if there's one reason to go on hormonal therapy, and this is one of the key decision makers that I have with many patients, it's to get a bone density test. If you have osteopenia or osteoporosis, I think it really needs to put your agenda forward as to whether you want to start with hormonal-based therapy. So again, this was the expert panel. This was kind of a brief review. There were more individuals that were speaking on the panel. So the highlights, basically, the boxed warning needs to have revisiting. Basically, we need to get rid of it because it's so safe, so that doctors will prescribe it, so that patients will use it. That we know that systemic therapy is different than vaginal estrogen therapy, okay? That the evidence shows that the benefit starts early. So within 10 years of your menopause is when you're getting the greatest benefit. It doesn't mean you can't start it after that age, but the greatest benefit based on the data from 20 years ago was when you start it within 10 years, okay? And that now we need the regulatory steps to come to make this change. So in Canada, what do we need to do? Well, we basically need probably for the American guidelines and the FDA to change, and hopefully that will bring our Canadian guidelines closer to change as well. So I'm going to stop it at here, and I think I've stopped my sharing, and I really just want to open this up now to any questions that you may have. It's a lot to go through. We've discussed most of this before in our hormone discussions, but do you have any specific questions on what was reviewed today? Or anything that anyone wants to ask in the chat box? You know, I think for me, it's a big step forward for women's health to have such a body, an expert panel to come forward. And although we have lots of debate within the menopause field of, you know, when to give, how much to give, you know, the North American Menopause Society guidelines versus the Canadian Menopause Society or these different bodies. But now we can discuss at least some of the safety, at least of the vaginal products. But I think really it's going to begin to open up the dialogue for more physicians to begin to look at this data in a special way. So any questions on anything else that you want to talk about today? So this is it, everyone. Hormonal therapy, it is very safe. Can you bleed? Yes, you can bleed. We don't have enough. The thing is, we don't have enough specific tests right now to say this is exactly where you are, where you need to be, because hormones change all the time. And even if I measure your blood levels, you can still bleed because, but very nasty. Yeah. Mm-hmm. And this is tough with the physicians. You know, I've actually, you know, there's a few of us physicians in the province that do this kind of work. And, you know, as I speak about this now, I think we really need to have a campaign within the medical society. And I think maybe this is going to be my drive to help to do this, because I've seen so many people be told by their physicians that this will cause you to have cancer, right? And doctors need to understand, they need to know better, and the word needs to get out. And so maybe this is what we, as the physicians that prescribe hormonal therapy, is we need to advocate even within the medical society. Okay, this is a challenge brought on me. I will take it on. Yes. And this is what I'm hoping to do, more promotion personally throughout the province in the upcoming year. But I think that as we team together as physicians, I think this will be beneficial as well. Because as you know, in New Brunswick, we've just got, the Well Nurtured Clinic, we've got Dr. Ouellette, and then we've got the Lux Clinic. Those are the 3 big clinics, and myself, that are providing hormonal therapy. But we have to get the word out there. And we know it's so safe because even, I've shared before, the Canadian Menopause Society, this was listed over 2 years ago, a pragmatic approach to menopause. And it says in the guidelines that physicians should have a discussion with their patients as they go through menopause about hormonal therapy, but many of them are really still old school about it. So thanks, ladies, for bringing up these points. Very important. So thank you, everyone, for attending today. It's always a great pleasure to come and to share information with you. So I look forward to seeing you next Tuesday at 7:30 for the Inner Circle. And if you like, next Wednesday at 7:30 for the first session of the Wise Woman Rising program. Okay, take care, everyone. Bye for now.